Hello and welcome to Doc Talk, a discussion about screening, risk assessment, and active surveillance in prostate cancer. These are all somewhat controversial topics with many thoughts, opinions, and sometimes heated discussions. We hope to help clarify the issues with this program, outline the areas of controversy, and provide you with some practical guidelines and recommendations. In addition, we hope that you will take away from this program enhanced knowledge regarding not only screening of your asymptomatic male patients, but also how to assess the risk of progression in early-stage prostate cancer, as well as the ability to determine when to recommend and consider active surveillance rather than immediate treatment for certain patients. So joining me for this educational forum are Dr. Gerald Andriole, Professor and Chief of Urologic Surgery at Washington University in St. Louis, Dr. Eric Klein, Chairman of the Glickman Urological and Kidney Institute and Professor of Surgery at the Cleveland Clinic, and Dr. Andrew Stevenson, Director of the Center for Urologic Oncology at the Cleveland Clinic. So thanks to all of you for taking time to join us and enlighten us on these controversial areas. So let's begin with Jerry Andriole, who will help us understand the issues and trials in prostate cancer screening and the recommendations of various interested groups regarding screening guidelines. So Jerry, tell us about screening.
Jim, thank you very much. It's a pleasure to offer my opinions on what I think we've learned about prostate cancer screening over the last decade or so, and what I think is the way forward. Let me just give you the summary right at the beginning. I think that we now know that mass population screening has a modest effect on reducing prostate cancer mortality, somewhere between 0 and a 40% relative risk reduction. Now, there is a trial in the United States, and we'll talk about PLCO later, that showed no benefit for the entire group of men undergoing screening, and I'll attempt to tell you why. There is a much larger European study, the ERSPC, that showed a 20 to 30% relative risk reduction in a predefined subgroup of men. This result was driven by 2 of the 9 sites, and we'll talk about that. All of the sites have not yet been reported. All of the patients have not been reported. And there are some concerns about treatment differences between the arms that could explain some of the effect of screening in reducing mortality. But notwithstanding those findings, we now know that the way we have been screening till now results in a significant risk of overdiagnosis of prostate cancer, which often results in a significant risk of overtreatment for prostate cancer. Treatment has side effects and it's costly, both in human and economic terms. And you know, prostate cancer may be the perfect disease to promote overdiagnosis. These criteria were spelled out a number of years ago, and prostate cancer fulfills every one of them. And that is that there is a large existence of a silent disease reservoir. Urologists and practitioners engage in activities that lead to the detection of prostate cancer, and this is a disease with a very long natural history and a limited prostate cancer-specific mortality. And just a few data slides on each of those points. Here's the prevalence of prostate cancer on autopsy. You can see that it's essentially the same percentage chance of prostate cancer as the patient's age. So it's a very, very common disease among elderly men in the United States. Well, what about activities that lead to the detection of prostate cancer, that is obtaining a PSA test? You can see on this slide that a majority of patients after the age of 65 are getting PSA tests, and that is a group of men where the prevalence of disease is approximately 60 to 70%. Very recently, these data were reanalyzed, and actually the rate of PSA testing in even older men, men over the age of 75, has actually increased in the last decade of life, And as you know, screening is most beneficial for the youngest men who undergo screening, not for men after the age of 75. And I will put this slide up here to point out that in the one randomized trial of radical prostatectomy as a curative treatment for prostate cancer, the benefit was limited to men below the age of 65. That men after the age of 65 did not have a benefit from treatment of their prostate cancer with radical prostatectomy. And it's very important to realize that that was a study of clinically detected cancers in men who were aged 45 to 64 years of age. where radical prostatectomy was effective. If we are looking for those cancers with screening, we have to start looking for them about 5 years earlier, because PSA gives us about a 5-year lead time to the detection of prostate cancer. And finally, this is a disease with a limited mortality. These are some of the larger screening trials that have been reported, and you can see that in the control arm, the ratio of death from any cause to the ratio of death from prostate cancer is somewhere between 30 and 40-fold times higher for some other cause of death rather than prostate cancer. And in the United States, there was a randomized trial of radical prostatectomy versus observation for men with screen-detected cancer. This did not show a benefit to radical prostatectomy, and even in that trial, men who were not treated with curative intent had a 5 times greater chance of dying of something other than prostate cancer. So this just underscores that this is a disease with a long natural history and a limited overall mortality. If we were to look at the world's best results for screening for prostate cancer, this would come from the Gothenburg arm of the ERSPC trial, and in some it would say that if there were 1,000 men screened and followed for 14 years, in 5 of those men would death from prostate cancer be averted as a result of screening and treatment. But along the way, it's worthwhile to point out that 127 of those 1,000 men would have been diagnosed with prostate cancer. And that underscores the magnitude of the problem of overdiagnosis of prostate cancer. And this was a very recent study looking at the results of the prostate cancer prevention trial in the United States and modeling the probability of a diagnosis of prostate cancer as a result of PSA-based screening. If you look at men who had a PSA of 4, they were 20% more likely to be diagnosed on a biopsy than they were to have been diagnosed with a clinical diagnosis of prostate cancer. They were 3 times as likely to be diagnosed as to ever develop metastatic prostate cancer, and they were again 3 to 4 times as likely to be diagnosed as their probability of ever dying of prostate cancer. Another way of looking at the problem with overdiagnosis. Now, I just want to spend a few slides explaining the PLCO trial. This was a study we did in the United States of 80,000 men randomized to screening versus not screening. The problem is the trial was not perfect, and the reason was that a significant proportion of the men, 30 to 40%, had been pre-screened prior to randomization, and this reduced the ability of screening to show a benefit in the screened arm. Furthermore, because PSA testing in the United States was very widely promoted, there was substantial contamination in the control arm. So instead of a trial of screening versus no screening, it was a trial where 85% of men in the screened arm got screened and about 40 to 45% of men in the usual care arm got screened. So this reduced the chance that this study would demonstrate a benefit for PSA-based screening. Finally, it's worth noticing that the cohort of men enrolled in the PLCO trial was a very healthy one. That based on our projections at the outset of the trial, their incidence of mortality was only 46% of what we expected it to be. This was a very healthy cohort that may not be generalizable to the U.S. population at large. And finally, I'll just make one comment about prostate cancer treatment in the PLCO trial. These patients were very aggressively treated, and they were treated equally whether you were in the control arm or the screened arm. And this, again, gave a result where the death rate from prostate cancer was only about half as high as we had anticipated it to be when we designed the trial. So if I could summarize PLCO, I would say that it shows that there's no benefit of organized annual PSA screening versus opportunistic screening. It was not a trial of screening versus no screening, and that the population studied was relatively healthy, and in that sense, it may not be generalizable to the population at large. Now, what about the European study? Now, the European study is actually a group of different studies because there were different screening protocols in some of the countries, and some statisticians believe that it should be analyzed as a meta-analysis, not as a single trial. Secondly, as I said before, the mortality reduction was observed only in a core group of men. It was not observed in all men, and all of the sites have not yet been included. And in fact, there were only 2 of the 7 countries where there was a significant mortality benefit to screening, and removal of those sites completely eliminates the overall benefit. And this is a forest plot of the mortality benefit to screening in the different countries of PLCO. And the one I would just like to emphasize is Finland. We already talked about Sweden, which showed the greatest mortality reduction of any of the countries in the ERSPC. Well, the Finnish trial, which was 4 times as large as the Swedish component of the ERSPC trial, had a very similar, very high overall death rate from prostate cancer in the control arm. Notwithstanding that, there was no benefit to screening in the Finnish cohort of the ERSPC. And that should be of some concern, because one might anticipate that in the countries with the overall highest death rate from prostate cancer, screening is most likely to show the benefit. And that was true in the initial analysis where Sweden and the Netherlands showed the benefit, but now we know that Finland, shown in the white there, is like the other countries where no benefit to PSA-based screening has been demonstrated despite the high overall mortality from prostate cancer. And finally, with regard to ERSPC, we have to say that it wasn't a perfect trial because there were treatment differences between the arms of that study. You can see that when you risk stratify for low-risk organ-confined, intermediate-risk organ-confined, or high-risk organ-confined disease, there were statistically significant differences in treatment. And I'll just draw your attention to the group of men who had high-risk localized prostate cancer, because this is where most of the prostate cancer deaths probably came from in the 13 years or so of follow-up. And you can see that men in the control arm had about half the chance of getting a radical prostatectomy in comparison to men in the screened arm, and also that men in the control arm were twice as likely to be treated only with hormone therapy in comparison to men in the screened arm. And finally, the authors of that paper made 1 or 2 more additional points, and that is not only were the types of treatment different, but the place where the treatment was administered was different. Men who were undergoing screening were more likely to be treated at large academic centers. They may have received better forms of radiation therapy and more aggressive treatment for their hormone-relapsing disease. So this is another source of inequality between the 2 arms. Now, where do I think we're going? Well, I think where we're going is summarized very nicely by the various guideline recommendations of a number of organizations, and I'm going to turn first to the European Association of Urology, and I'll point to the third statement, statement number 3, a baseline serum PSA should be obtained for men at the age of 40 to 45 years of age. Why? Well, this was an observation we made in the PLCO trial in the mid-2000s, and it showed that men who had a PSA below 1 had an extraordinarily low risk over the next 6 or 7 years of developing a high-grade prostate cancer. And later on, analysts from ERSPC essentially showed the same thing, but expressed it a little differently. If you were to continue to screen men who start out with a PSA below 1, you would have to screen 24,000 men for 13 years. You would have to treat 724 men for prostate cancer to eliminate 1 man from dying of prostate cancer. So it's really not a very efficient way to do it. And finally, the results from the Malmo prevention trial are shown here. And in summary form, it may be a little clearer to show on the third bullet point that among the 75% of men who had a PSA level below 1 at the age of 45, well, those men had less than a 1% 15-year risk of either dying of prostate cancer or of developing metastatic prostate cancer. If they had a second test a few years later that was still below 1, their 15-year chance of either of those events was less than 0.2%. If they had 3 such tests and all their PSA values were less than 1, the authors suggest that they should be exempt from screening because their 15-year chance of metastases and death from prostate cancer is extraordinarily low. Here are the guidelines from the American Urological Association, which mirror many of the things we already said. The notable things are that screening is recommended for men between the ages of 55 and 69 years of age, and that the screening interval is recommended to be every 2 years instead of every year. So this may further reduce the chance of overdiagnosis and overtreatment of prostate cancer. Finally, the NCCN guidelines for early detection have just been released, and the changes in the guideline are shown here in magenta. It shows, again, that it is recommended that PSA risk stratification occur for very young men in their 40s, and that those men then be dichotomized by whether or not their PSA is above or below 1 and followed accordingly as shown on the diagram. And you can see the recommendations for patients who are older and whose PSA is greater than 3. Finally, I think hats off to some of our collaborating investigators in Europe who are going to do a randomized trial of this sort of risk-adapted PSA-based screening on the baseline PSA of very young men. We'll certainly keep a watch out for this study because it really does have the opportunity to significantly improve the way we use PSA. So in summary, I would say that we have learned that PSA-based screening certainly can reduce prostate cancer-specific mortality. But on the other hand, mass population screening based merely on age is not the optimal way to do it, that we really should do risk-adapted PSA screening in an effort to minimize overdiagnosis and to find the men who really need to be treated for their prostate cancer. Even with that approach, though, it seems that overtreatment will still potentially be a problem, and the urological and oncology community really has to adopt active surveillance and other focal ablation treatments for prostate cancer. And finally, I'm extremely optimistic, as are many of my colleagues, that new markers that are being developed to aid in the diagnosis of prostate cancer and further in predicting the future course or the prognosis of a diagnosed prostate cancer should further increase the overall benefit of PSA-based screening. Thanks very much for the opportunity.
Okay, so Eric, let me pick on you for a second. So what do you recommend when family physicians and general internists ask you how they should approach screening for their healthy males in their 40s or early 50s?
Yeah, my take on the data is very similar to what Jerry has presented, and I like the new NCCN guidelines. I do think that there's benefit in terms of determining lifetime risk of cancer and screening men beginning at a young age and then risk stratifying how frequently they get screened subsequently. That makes a lot of sense to me.
Does family history or race change those guidelines?
So I would say that it reemphasizes the fact that those individuals are at higher risk of developing prostate cancer and they need to be in the system early, and then one needs to make individual judgments about how frequently they get screened after that. There aren't hard and fast rules for those two groups yet. Very
good. Andrew, any comments?
I agree with what Jerry has said. I think we have to be more intelligent about how we screen patients. We have to be mindful of their patients' comorbidities and their likelihood of benefiting not only from an early diagnosis of prostate cancer, but also from early intervention. One thing that Jerry didn't mention, but I think is worth mentioning, is the Malmo study that he referred to. They also looked at the impact of a PSA level at age 60 and their risk of subsequently developing aggressive prostate cancer. So if you're a 60-year-old male and your PSA is less than 2, your likelihood of developing an aggressive prostate cancer over your lifetime is extremely small. And I think these early stopping rules, which I employ in my practice, and I would encourage primary care physicians to do the same, is really, I think we're going to make the greatest impact on the overdiagnosis problem.
Right, and it seems like since PSAs became available and there were lots of diagnosis made, that a lot of physicians are ordering PSAs annually until people are lowered into the ground. So if the PSA is less than 1 for someone in their 40s and 50s on 2 or 3 repeats, screening can just stop at that point?
Well, that's what the guidelines would seem to suggest, yeah.
The data support that, actually. They do. And I think what we've learned, what Jerry outlined nicely, is that screening everybody once a year starting at age 50 until they die does not save lives at the population level. And so we got to stop doing that.
And cost a ton of money.
Exactly.
Very good.
Yes.
Now I didn't use the acronym U.S. Preventive Task Force at all.
Right.
I do think that what was portrayed in the popular press, that their guideline is against screening, is a little overdone. So I wouldn't want the listeners here to hear the message that there should be no screening at all. That is not the case. What we want to do is more intelligent and selective screening.
Right.
So I think that program that you discussed, that the trial is going on in Europe where it's going to be risk-based screening pattern, that makes sense. And for most people, even if you don't fall in that less than 1 on your PSA, every other year should be adequate?
It seems that
Yes.
that's frequent enough.
Good. All right.
Yeah, there's solid data from the European trial to support that.
Very good. I think those are great take-home messages. All right. Well, we'll take a brief break and then we'll be back and talk about risk assessment for those patients who are diagnosed with early-stage prostate cancer.